So Merlin 001, right? What is this? So Merlin 001 is beautiful in my mind because it's a validation study, but it's a particularly high quality study because we did the study prospectively, right? So we started basically from scratch, enrolled patients, and then studied the performance of our Merlin test in a very controlled, very real life sort of way. At the end of the study, you have a very good idea what a test result actually means for your patient. There's competitors in the market that have never done this. I already alluded to the fact that their models may be built on noise. Validates differently in every cohort that it's used on. And so if you get a test result, you don't really know what it means. You can't assess whether you can trust it, you know. With Merlin 001, we now have done this study where you can actually, you know what this test result means for your patient. So it was a big study, right? So we included, I think we screened over 2,100 patients, and then in the end we had, I think, 1,761 patients that were successfully screened, got a sentinel lymph node biopsy, and a molecular test result. And these patients were recruited from all over the country, very diverse patient populations. So, you know, we had cancer centers participate in Michigan, Florida, New York, Mayo Clinic at its 3 sites, you know, Utah, I mean, other places. So we had these different sites participate, patients were enrolled, we got the, you know, final data set for our primary objective, which was to kind of study predictive ability of Merlin, you know, predicting sentinel lymph node status. And we got some pretty amazing results. So first of all, I would say we found that the test truly works because it's unequivocal that there's a very big difference in risk between high-risk tested patients and low-risk tested patients, about a 3-fold difference in risk. So if you're low-risk tested, overall in this entire group of patients, you had about a 7% risk of having a positive node versus 21% if you're high-risk tested. So big difference, no overlap in confidence intervals. So clearly there's risk stratification going on. So that's the first message. And then the second message is that, yeah, if you have a low-risk Merlin test result, your risk of having metastasis in the lymph node is very low, okay? It's for sure below 10%. And then for different subgroups, it might actually be below 5% or close to the 5% threshold that people always consider to be important threshold. So very low risk for the low risk tested Merlin patients, but then like very high risk for the positive, the high risk tested patients. The study was very real world, very well done. We found the test works. We found that it reduces the risk of patients if they test low risk, increases the risk if they test high risk. And so it's a very good product, right, that will provide information to patients that they didn't have previously. So how do we see it working? Well, I think in terms of referral patterns and how patients are treated by dermatologists, surgical oncologists, nothing much will change there. Patients will still meet with their surgical oncologist if they're a little bit higher risk to discuss the surgical procedure. And then dermatologists also can use the test to help their colleagues in surgical oncology get the test results and make better decisions, but they can also use it on the earlier stage melanomas, something we call T1A melanomas. Sometimes we have this problem in dermatology that we have a melanoma, it's a T1A but slightly on the thicker side, maybe it's 0.5, 0.6, 0.7 millimeters, and then there might be something else going on. Patient might be younger, there might be mitotic rate or lymphovascular invasion. Or we're uncertain about the Brazil thickness because the biopsy was transected, or measuring Brazil thickness is difficult. Then sometimes we don't know what to do. Is this now low risk or high risk? Should we send to surgical oncology or not? So for these types of patients, we have a great tool available now to kind of stratify them in terms of their risk and make decisions on where to send them. So, you know, what else was special about the Merlin study? It was a prospective study, like I already mentioned that, and it was also blinded, meaning that the physicians that treated the patient didn't know the test result, and the lab that processed the test didn't know the results of the sentinel lymph node biopsy, so that there was no sort of interference with the way either the test was reported out. I was just talking to some physician assistants in Michigan, and it just occurred to me that we're the only test in the market that has this level of validation and where you truly know how to use it based on your validation data. And there's no other test is out there where you can really trust the test results, and you really know what they mean, because all the validation work was either sponsored by the company, everything was retrospective in nature. So yeah, I think it's amazing that we've done these validation studies. I think we're at a really good point right now where we have a very good idea how to use the test.